Okay, so hello, Bob, and happy Sunday afternoon.
Uh, Good afternoon, Tammy. As always, nice to see you.
You as well. And I want to thank you, first of all, for joining us again this last weekend to speak with our Parkinson's group here in the Villages. And it's always a pleasure to have you.
Thank you.
I had one gentleman who nudged me and he said, "Oh my goodness, that man is so smart." And I'm like, "Yes, he is." So it was, the information that you share and that you're generous with is just always just a thrill. And then your preparation is noticed. The fact that you don't come in there willy-nilly, you're very prepared, and that means a lot because it shows us that you value the group and you value those you're talking to. So that's huge. I want to just note that.
Thank you. Thank you. And I'm always glad to help them. I really am. It's a great group of people, and they're thirsty for knowledge. And I love that. And if, I can talk for hours with them if time allowed, but they always show a great deal of interest, which really I just feed off of that. So, but it was, as always, yet again, another very successful afternoon. I do have a few questions that I was not able to answer or get to, because there was a ton of them at the end of the meeting.
I bet.
So I got to almost all of them, but there were three pretty interesting ones that I'd like to just quickly answer for those people that I wasn't able to. One of the first questions that came up was whether or not that they can use more than one antidepressant at a time. And that actually leads me to really why I wanted to do antidepressant, depressant medication, and anxiety, because believe it or not, almost 50% of the Parkinson's population is affected by depression and or anxiety at some point. And that kind of makes sense since, as I mentioned in the meeting, mood is triggered and modulated by chemistry in our body. And dopamine plays a role in that, and of course, serotonin and norepinephrine. But we all know what important role dopamine plays in Parkinson's. So clearly, at some point, it's going to affect mood and behavior. So to answer the question is, yes, you can use more than one antidepressant, but we have to be careful what groups we select them from. It would be nice in a perfect world if just the doctor right off the bat was able to pick the right one all the time and everybody gets resolution. But we all know in the real world it doesn't work that way. So what can happen is very often you may get on an antidepressant and then you got some improvement, but you really weren't happy with it. You were not at 100%. So what either the neurologist and or a psychiatrist will do sometimes is they'll pick another drug from a different category, not the same category. So for instance, let's say they started you off on sertraline, which is Zoloft. They couldn't add another drug from that same group of antidepressants, which is the SSRIs. That would lead to possibly a very serious elevation in serotonin levels, and that could be problematic for a lot of patients. But we could take another drug from one of the other categories, for instance, bupropion, which belongs to the SNRIs. No, I'm sorry, not bupropion. Yes, bupropion. Yeah, that's an atypical. That has no effect on serotonin. So that only affects norepinephrine and dopamine. So they could add that to your sertraline regimen without having to be worried about any other additional side effects. Bearing in mind, now that you're adding another antidepressant, that could take several weeks to kick in and work. As we discussed, all of these drugs take a while to work. So these patients have to be very patient with it. Some aren't, which leads to compliance issues. But yes, so the answer to that question is the doctor just has to be sure be careful as to which category he's going to select them from.
So I have a question real quick. I hope to not cause you to lose your train of thought. What would be the benefits of multiple antidepressants as opposed to upping a dosage, let's say? I'm just talking completely as a layman. I don't.
Yeah, and it's funny because that's exactly the next question that came out about elevating the dose. So what happens is, as we know, these drugs, each class works on different neurotransmitters. So
Okay.
in some patients, just an SSRI like a Zoloft, Prozac, Celexa, Lexapro, those are all SSRIs, and they really help to modulate only one of the three neurotransmitters, serotonin. But maybe some patients need elevation in the other neurotransmitters. Maybe they need a little bit boost in their norepinephrine or their dopamine level. So by adding, for instance, as I mentioned, a bupropion, which goes by the brand name of Wellbutrin, that also that doesn't affect serotonin, but it affects norepinephrine and dopamine. So now the combination, you have two drugs that are now modulating all three neurotransmitters: dopamine, serotonin, and norepinephrine. And that combination may be just enough to take that person over the edge and get them to where they want to be with their depression. And again, the physician can't just magically look at you and know which level needs to be adjusted.
Right.
So there's a lot of trial and error sometimes. And again, that leads to impatientness.
Yeah. So I sorry, I have all sorts of questions with your three, like these ones. Now, could there be an outside of the typical side effects which you covered, when you're taking one of those medications to increase norepinephrine and dopamine, how does that work for your levodopa? Because you're already doing something to help with your dopamine. Tell me like the effects there.
Yeah, so again, there's only a select few of these drugs that have a role in elevating dopamine. And bupropion happens to be one of those. So again, now for some patients, that may be very advantageous because now they're going to have a little increase in dopamine at their neuron junction, at the synapse. So that could be advantageous. It could be problematic by starting dyskinesias, because maybe their dopamine levels have gone up a little bit too much. So that has to be monitored. And again, which is why it needs to be done in the hands of the pros, because they will be monitoring that as well. Someone, for instance, you and I, it's not that much of an issue having that little boost in dopamine levels, but we're not supplementing with levodopa. So that can be problematic for some patients. To other patients, it could be a welcome relief. Who are experiencing a lot of off time, for instance, and the best cure for off time is to elevate the level of their levodopa. But then if you elevate the levodopa too much, now you're going to get dyskinesias. So it's a very delicate balance in there. And to go back just a little bit onto one of your other questions about increasing the dose, this was a question that came up also afterwards. I had a young gal came up to me and said that she had been on bupropion for several weeks, a couple of months actually, and really wasn't seeing what she wanted out of it. And she wanted to know, that was the 150 milligram dose. They do make it in a 300. She wanted to know, can I have the doctor just increase the dose? And on the surface, that sounds like a very logical thing, but it's not. There's problems with that. The first and foremost is it doesn't always mean more is better. And we love more. We're a society of excess.
Right.
So we love to go up there and take that higher dose. However, the more we take, the more likelihood of side effects are going to be created. And that's where we run into trouble. So not that that's off the table. Sometimes that works. But I think a lot of times what physicians would do, rather than increase the dose and subject the patient to additional side effects, perhaps the addition of another antidepressant and or an anti-anxiety agent in addition to that might be more advantageous than just doubling the dose from 150 to 300, and let's just see what happens. So sometimes that works, but very often I find in the real world, the doctors are more tempted to add a second drug to the regimen than increasing one drug.
That makes sense, especially when you explained about, pulling from different neurotransmitters.
Yeah, absolutely.
Makes a lot of sense, like that. You said you had a couple more questions.
Yeah, one other that came up was that they asked if there was a particular side effect that they should always look out for. Is there one bad thing about all of these antidepressants? And the truth of the matter is, I don't necessarily know if there's one. There are a couple that I think really should be looked at for. The first and foremost is going to be an effect on weight. These drugs very often can, depending upon which class you're picking from. For instance, if we were going with the SSRIs, which is the Prozac, Lexapro, sertraline, Zoloft, all of those, they have a tendency to elevate weight. Now, for people who don't have Parkinson's, that's a huge problem. No one wants to take a drug and get fat while they're taking it. But for some Parkinson's patients, weight gain may be very advantageous. Very often they're dealing with other comorbidity issues, or they're having dysphagia, where they're having difficulty swallowing, so they're not eating properly, or they've lost their sense of smell, which means they probably are not tasting their food, so their caloric intake is dropped. Now they've lost weight, they become frail, and frailness means they're unsteady and they fall. So that's a bad thing. So having one of those, picking a drug from that class might be very advantageous for a certain population of patients. Other groups, for instance, some of the atypical ones, like the bupropion that I mentioned, that goes the other way. That causes weight loss, mostly because that class of medications deals with craving. And that's one of the reasons why they used to use it to help stop smoking, because it helps to alleviate cravings, whether it's craving for nicotine or a craving for food. So again, perhaps that may be advantageous or a disadvantage to some patients that are already thin and frail. If to put them on a product like bupropion, not that they can't do it, but you would have to be very closely monitor their weight on a every other day or a weekly basis. And the other thing that we have to be careful of too is there's another drug, mirtazapine or Remeron. That's a drug that stimulates appetite. Here again, that may be advantageous. In addition, it causes tremendous amount of sedation. So if you have a patient that is suffering from insomnia, very common in Parkinson's, and at the same time, we need to stimulate their appetite because they haven't been eating properly, this would be a wonderful choice for a patient like that. They can get the sleep that they need and additionally help stimulate their appetite so that maybe their caloric intake will increase. So weight loss is one of the big things. Blood pressure is the next one. Yeah. A lot of these drugs can, because they affect norepinephrine, which is a very potent vasoconstrictor in our body, that can elevate blood pressure. Again, Parkinson's patients very often have low blood pressure or orthostatic hypotension. So for that certain population, that could be advantageous, picking one of the drugs in the groups that affect norepinephrine. That could be very helpful. And finally would be GI issues. I mentioned there's usually a collection of four: nausea, vomiting, diarrhea, and constipation. Now, the last thing a Parkinson's patient needs to deal with is a drug that's going to add to their constipation issues. So that can be very problematic for them. So that needs to be looked at. So weight, blood pressure, and GI issues are the big three that the doctor needs to take into consideration, obviously, for a Parkinson's patient specifically.
Right. You said something, it almost seems like, I don't know, when you said the one was the one that you just mentioned it, and I was trying to take a mental note of it, which helped with cravings. It caused cravings, and it put you to sleep.
Bupropion, yeah.
It almost seems like if I were struggling with like insomnia and like the struggle with weight gain, that would sound like a wonder drug. However, that one does have the side effect that can happen with the GI as well too, right? So
yes, yeah, absolutely. Yeah. Yep. And again, I mean, there are other side effects we talk about. There are sexual side effects that we spoke about the other day. So those need to be taken into consideration depending upon the patient's age and things of that nature. But again, those other side effects that I mentioned, we have ways of resolving those. Some of the ones that I just mentioned, the weight gain and blood pressure, they're very, very difficult to monitor and maintain. So those are the ones that stick out for me anyway. If I was counseling a patient that was just starting these medications, those are the things that I would clearly make sure I brought to light for them.
Trazodone. Well, how does it,
Yes.
that's in that same, is that the same, similar?
That's another atypical, but we use that mostly for sleep nowadays. It never really gained popularity as an outpatient for an antidepressant, although it's actually officially indicated as an antidepressant. I don't believe it's indicated as a sleep aid, but we use it that way for a couple of reasons. One, it's not a narcotic, so there's no addiction liability. Two, is very likely it's not likely to interact or be concerned about like we would be with a barbiturate or a benzo. You don't have to worry about things like that. The problem was that as far as using it as an antidepressant, the dose had to be so high that it was ridiculous. I mean, the antidepressant dose for trazodone is 400 milligrams. So as I brought to light on Friday, if 50 milligrams is your nighttime dose, can you imagine where you would be if you had to take 400? So it never really played out in the outpatient world. However, it is still used, I'm sure, as an antidepressant at that high dose if you were an inpatient. If you had to be put into a psych unit or in a facility of some kind, they wouldn't hesitate going as high as 400, even 600 milligrams as an inpatient. But you could never walk around with 400 milligrams of trazodone in your body. That's just not happening.
Well, it would take care of your depression because you would just sleep through it all.
Exactly right. Yeah, you would have a happy, sleepy patient.
There you go.
That's what it would be.
All right. I have another question in a minute, but I just want to make sure you got all those, those couple of questions answered that you wanted to right away. Is there any more that you want to address?
No, my list is clear.
Okay, you brought up something, and again, for everybody, we're going to do another video and have Bob just go through his entire presentation with the different groups of drugs. So I think that'd be great to just put that together in a group, in a series that
Absolutely.
would be beneficial. But something that just really jumped out at me was you had mentioned something, and I think it was in the category of anti-anxieties. And how a concern with people taking anti-anxiety is a certain, maybe one or all of them that are prone to hallucinations. And was it just hallucinations?
Hallucinations and delusions as well.
Okay.
Yeah, so a good point, because although we had a wonderful selection of drugs for antidepressant, used as an antidepressant, we don't have that same great selection when we're dealing with anxiety with Parkinson's specifically. We have what we call the group called the benzos or the benzodiazepines. And of course, this is good old Valium, which has been around for a long time, diazepam. We have Ativan, which is lorazepam, clonazepam, which is Klonopin, and alprazolam, which is Xanax. So pretty much all of these names are household names at some point. We've all heard of them over the years. They've been around for a long time, and they're extremely effective as anti-anxiety agents. And the doctors really loved it. As prior to that, the only thing we ever treated anxiety with was barbiturates, phenobarbital, pentobarbital, secobarbital, and they work too. They work very similar to the current benzos, but they had a lot of side effects, a lot of sedation, a lot of respiratory depression came along with using those. That was a big concern. And they have a very narrow therapeutic index. So meaning that you have to be very careful. If your dose just goes a little bit above that therapeutic index, you're talking an overdose situation, which can really be a problem for a lot of patients. So they had to be very careful. Then when the benzos came out, not that they eliminated respiratory depression as a side effect entirely, but they reduced it substantially to the point where it's not really a big issue anymore. And boy, oh boy, the physicians jumped on that right away, which is why these drugs like Valium took off immediately. They are effective, but they have a problem in the Parkinson's population, and that is they cause some lethargicness, some drowsiness, confusion, and that's a bad thing, especially if they have to get up in the middle of the night. It can also bring on or worsen hallucinations sometimes. And that's really a bad thing.
Right.
very often, they take one of these benzodiazepines at bedtime, for instance, to help them with their anxiety, so that they get a good night's sleep. They don't become anxious or whatnot. And then now all of a sudden they start hallucinating at night too, and then they possibly get up because they're confused. And of course, that the ultimate thing there is a fall. That's
Right.
the worst thing. But there's another form of anxiety that Parkinson's patients experience, and that's called the end of dose anxiety. And that comes about right at the very end of their levodopa carbidopa dose and the beginning of their next one. Right at that time frame, a lot of patients, this is what they refer to as a dopamine-based anxiety. As that dopamine level begins to drop and they're ready to take their next dose, they're right in the mix between one dose ending and the next dose coming in. Now, if you gave them, if that patient was to take a benzodiazepine, they wouldn't get any relief from that, because that's not what their problem is. Their solution is more dopamine. They need dopamine because that's what's causing their anxiety. But so that's a completely separate issue. It doesn't happen to every patient. So those, again, this is going to take their neurologist to sort that out for them. They just can't think, oh, I'm going to take some Xanax and my anxiety is going to go away. But if your anxiety is a dopamine-based anxiety, you could take all the Xanax you want. It's not going to help you at all. So that's going to take one of the pros to sort through that. But I just wanted to mention to them that that does happen to a lot of patients. They get very nervous, very anxious right at the end of that dose. And that's a different type of anxiety than we can see. But we can use those anti-anxiety agents along with the antidepressants. And a lot of the antidepressants can help with anxiety without having to stay on the benzos for any length of time. They may use the two combinations in combination early on, but then as the level of the antidepressant begins to go up, the doctor will begin to trimming down the dose of the benzodiazepine to the point that will eliminate that. And now the patient is just on the antidepressant, which works for both the anxiety and the depression.
Neat. Interesting. So outside of, now when we opened up some questions, so I'm going to go outside of the antidepressants and the anxiety medication, and we'll jump back on that in our next video and just be really thorough, because it's good stuff, and I'm sure more questions will come up at the end of that conversation. But one thing that came out, a question I thought was really interesting, there's a couple, but one I think is important to address early on, and that was question regarding supplementation, but without getting completely on supplementation, specifically iron. You brought up a point about iron, and we can go to supplementation. You can add on to that as well. But like, bring out the cautions on iron, and then there was a few other things that you're like, these are the most important. So take it away. Yeah.
So that question came up because someone had asked about supplementations. What kind of supplements should I take? And so we were going over a list of things that I thought, or I see a lot of patients take. And when we came to the multiple vitamin selection, I had said to them, be very careful, because a lot of the multiple vitamins, they like to sneak in iron into the formulation. And that's probably not a bad thing for the general population. But for the Parkinson's population, especially those that are on levodopa carbidopa, that can be problematic, for the reason being that the iron can bind up with the levodopa and not make it available for use. And of course, that's just a wasted dose, number one. And number two, you're not going to get any benefit from that dose because of the iron. So a lot of nowadays, I see on the shelf when I go to the store, they have like a men's one a day and a women's one a day. They seem to separate them all the time. But so now, of course, if you've already been diagnosed with an anemic condition and you've been told by your physician to take iron, I'm not suggesting in any way that you stop taking it. Of course, it would be best if you could space that out. Ideally, an hour would be wonderful from your levodopa and your iron, but please don't stop it if you've been told to do it. However, if you're just taking a multiple vitamin off the shelf because you just for general good health, be very careful as far as if they've snuck in iron somewhere in there, especially on the women's side. They always love to stick a little iron on the women's version, more so on the men's. So be very careful with that selection because iron can interfere with levodopa without a doubt.
That was good. You answered I was like, immediately I had a light bulb moment of like question, hey, what about spacing it out? So if they do space out, I mean, if they're taking an iron supplement because they've been told to, recommendation is to make sure that they're not at the same.
Don't ever stop taking that, especially if you've been told to. You can take the two to get, within the same day, just not simultaneously. An hour would be ideal, or, but if that's possible, try the best you can with that.
With that, would foods high in iron, would they have the same effect?
Yep. Yeah. I mean, if you were a spinach eater, let's say, or just basically your green leafy vegetables, that could be problematic sometimes if you're having a nice big salad, thinking you're doing yourself a favor, and while you're taking at lunchtime, and then you're taking your levodopa, that might be an issue for you. Of course, the concentration is much less in these green leafy vegetables than there are in a single tablet, but nonetheless, it could pose a problem. If you've noticed any changes, you may want to try separating that or avoid those green leafy vegetables within an hour or two of taking your levodopa. You'll definitely notice a difference, that's for sure, because more of it's going to become available.
Interesting. Yeah, that's because you think we know to not eat protein with our levodopa, but now just maybe save that. And I am a spinach salad girl, so save that spinach salad for an hour after the levodopa.
Absolutely, it's a very popular. Even if not, or they just add some spinach leaves to their salad or whatever. And we don't often think about food-drug interactions, but they're out there. And again, going back to the levodopa, fatty foods. That's an issue too. If you're going to sit down and have a double bacon cheeseburger from Johnny Rockets and then take your levodopa, that's a problem because fats don't get metabolized as quickly as protein and carbohydrates. They stay in the stomach a lot longer. And as a result, in which we've spoken many times, levodopa does not like to be in the stomach. It wants to be in the small intestine. So if you're eating a meal that has a high fat content, the stomach's not going to release the contents of it until it's fully digested or broken down. And that takes much longer than a protein does. So that levodopa that you took with that double bacon cheeseburger is going to sit with it until it gets passed on into the small intestine. And the downside to you is that you're sitting there waiting for that levodopa to kick in, but it's not. It's hung up with the burger.
So that's where the elevator comes in. You take your levodopa, let it go up, then eat your Johnny Rockets.
There we go. Yes, exactly right. Exactly right.
I remember the illustration.
I see that. Very good. I'm very impressed.
We got about 5 minutes left.
Okay.
And one aha moment that I got, more than one person, probably 3 people, it came to me immediately to respond to was the correlation between melanoma and PD. And so let's finish with that conversation. That was a good topic. Yeah.
Yeah, and I try to bring that up as much as I can, only because it's a weird thing.
Yeah.
No one wants to connect, skin cancer to Parkinson's or being in the sun problematic for a Parkinson's patient. And to be perfectly honest with you, as much as I tried to look into it, I really couldn't find, and I don't even think they still know what causes that connection. However, the dermatologists have known about it for many, many years. And it kind of goes like this, that Parkinson's patients, for some reason, are 5 times more likely to develop carcinoma of the skin, we refer to as melanoma, than someone who doesn't have Parkinson's. And the really weird part is patients who have had melanoma are 5 times more likely to develop Parkinson's. So there's some kind of cross relationship there that is very difficult to find any real good science behind it as to why. I'm sure it has something to do with the melanin in the skin, and dopamine plays a role in the formation of melanin, which pigments our skin. But the point I try to make in these presentations is, hey guys, look, we live in literally the sunshine state. So, and don't always think of melanoma as those parts of our body that are exposed to the sun. I can promise you it can go in any area of our body. Yes, it seems to be more prominent when we're those parts of our body that are exposed, which is why I tell people that at least once a year, go to your dermatologist, a board certified dermatologist. Let them know, number one, that you are a Parkinson's patient, because that right away will trigger exactly what they know what to look for immediately. And they're going to, and tell them that you want a full body search as far as skin cancer, even in the parts that don't react to the sun so much, where the sun doesn't shine. And they will go everywhere. And it's important only because when you look at the statistics, 99% cure rate if they catch the melanoma when it's isolated in one single area. 99%. That drops to about 65% once it metastasizes locally around the original location, where it hasn't gone too far from where it started. You've got about a 60% survival rate. After that, when it's metastasized way past the original site where it started, the survival rate drops down into the low 30s. And so now you're talking about a 70% fatality rate from melanoma once it metastasizes outside of its original location. Those are terrible numbers, absolutely terrible numbers. And they don't have to be that way. They're easily preventable. Get the derm to look at you once a year. They're slow growing. So if there's nothing, that's why they tell you to do it once a year. Stay on top of it. It takes 5 minutes. Once you finally get in the examining room, the exam itself only takes about 5 minutes. You spend more time in the waiting room than you'll ever do in the examination room. And then you don't have to worry about it for a year. And if he does spot something, like I say, they can get the 99% survival rate when it's caught early. So please, it's very important to follow up with that.
That's great advice. And is there any difference between men and women? Do you of that stat of that 5% more likely?
No, as far as the melanoma is concerned, no, it doesn't seem to be selective in that case.
Just straight up people with Parkinson's.
Yep.
All right, interesting. So so that was great. That was a great piece of advice to leave people with, just to kind of be on it. Get to your dermatologist. That full body, that would be hard.
Yeah, I know. That's
but we all have to do it for different reasons. But
yeah, absolutely. I mean, you just get past it. It's like I say, the exam is very, very quick. So
right.
That's really a no-brainer for these doctors. They do it all day long.
Get her done. Yeah, absolutely. Well, such great advice, such great information, and lots of practical stuff too. I like that to be able to tie the practical aspect to all this.
Yeah.
And so I appreciate that part of it all. Now, I'm going to let us go because we're down to the last the last minute and a bit.
It always goes so fast.
It does. It blows my mind, but we will be continued. The next time we'll go through those categories of antidepressants and really dig into information regarding those and other questions that probably will arise between here and now.
I'm sure. Absolutely.
All right, Bob. Enjoy the rest of your afternoon.
You do the same. Nice seeing you, Tammy. Take care. Bye-bye.